Hello, I'm Pietro Gareri. I'm a geriatrician and the head physician at the Center for Cognitive Disorders and Dementia, Catanzaro Lido, ASP Catanzaro, Italy. In this short video, we're going to speak about MCI and early dementia. MCI refers to the transitional state between the cognitive changes of normal aging and very early dementia. It is a complex entity, phenotypically heterogeneous, with no certitude of conversion, and it is characterized by cognitive complaint, not normal for age, people are not demented, essentially there are normal functional activities, and there is objective evidence of memory impairment in one or more cognitive domains, typically including memory. The most commonly used tests are MMC and MoCA test. MoCA test seems to be more sensitive. MCI can be distinguished into amnestic and non-amnestic, and both of them include single or multiple domain. Amnestic MCI single domain is characterized by memory impairment only. Regarding the conversion rate to Alzheimer's dementia or other kinds of dementia, after 2 years we have that amnestic MCI probably evolves towards AD in 6% out of cases, and multiple domain in 48%. And anyway, we need to rule out vascular, traumatic, medical causes of cognitive decline when possible, and provide evidence of longitudinal decline in cognition over time. To this aim, we need to investigate folate, vitamin B12, vitamin D, thyroid function in the blood, and perform brain imaging CT-MRI scan. By far, the amyloid hypothesis is the most accredited one for AD, but not the only one. There are some biomarkers of A-beta deposition, for example, CSF A-beta 42, PET amyloid imaging, and of neuronal injury, CSF tau phosphorylated tau, hippocampal volume, or medial temporal atrophy on MRI. Useful information derives from FDG PET imaging, which can show early reduced glucose metabolism in the posterior cingulate when there is the progression of MCI towards AD, and later on it can decrease in the associative lateral cortical areas. So, there is a continuum between normal aging, mild cognitive impairment, and after a latency time, dementia. Dementia of Alzheimer's type is the most frequent one, about 47%, followed by mixed vascular frontal lewy body dementia, and there is also dementia related to internal or neurological disease. The possible causes are the accumulation of abnormal proteins such as beta amyloid or tau protein in AD, accumulation of free radicals, or brain circulation deficits. The possible risk factors are familiarity, hypertension, obesity, diabetes, and metabolic syndrome. Recent evidence has confirmed that A-beta deposition starts about 30 years before the clinical onset of dementia, and it can be detected through PET amyloid imaging. Anyway, the final pathway of neuronal damage is a cholinergic neuron, and we must take it into account for pharmacological treatment. The main symptoms and the possible evolution are different according to the kind of dementia, and memory loss is the most common aspect. For example, in the first stage of AD, we can have memory loss, anxiety and depression, or disorientation, language disorder, and so on. The possible treatments are different. It's very important to early diagnose MCI and dementia. It's important to prevent them through diet, for example, through the Mediterranean diet, exercise, 20 minutes walk 2 to 3 days a week, adequate control of the risk factors. Also, environmental factors are important, promoting self-sufficiency in patients, avoiding overzealous care, encouraging fun and recreational activities, The pharmacological treatments must be started as soon as possible. Cholinergic precursors such as cholinol phosphorate, citicoline have been shown to be effective in MCI and dementia. This was shown by the ESCOM-ALVA, IDEALE, CITRIVAD and citicolinage studies. Other possible drugs, homotaurin, palmitoyl-ethanolamide plus lutein, and in Alzheimer's disease, cholinesterase inhibitors plus or memantine or alone. Drugs for behavioral disturbances are used if it is necessary. The future perspectives in AD are disease-modifying drugs able to reduce A-beta aggregation or increase A-beta clearance, and immunotherapy, both active and passive, is very important, but so far results are inconclusive. We're expecting something else for the next future. By now, the only thing that we can do is to potentiate the available treatments.